Well, good morning and good afternoon and good evening to all of you. Thank you so much for joining us for this webinar and panel discussion today. We're very excited on behalf of the SIOP Epidemiology Network to have this discussion on challenges and opportunities in low and middle income countries for childhood cancer research. We have a panel of 3 outstanding speakers who will share their perspectives. And we will begin with some comments from each of the 3 panelists, who I will introduce in a moment, and then move on to discussion with the audience and group. So without further ado, I will introduce our speakers. Dr. Eva Steliarova-Foucher is a scientist at the Cancer Surveillance Branch of the International Agency for Research on Cancer of the WHO. She studied at the Comenius University in Bratislava, Slovakia, at the London School of Hygiene and Tropical Medicine, and obtained her PhD in 1994. She has worked with the Slovak National Cancer Registry and joined the IARC in 1994. She currently leads the IARC research team, Child Cancer Awareness and Research Evidence, and she also leads several international studies of childhood cancer burden, including international incidence of childhood cancer, cancer risk in childhood cancer survivors, among others. She is a member of the International Society of Pediatric Oncology since 2015. And after Dr. Steliarova-Foucher makes her remarks, we will hear from Dr. Joyce Kambugu, who is a consultant pediatric oncologist and head of pediatrics at the Uganda Cancer Institute in Kampala. She trained in pediatrics and child health at Makerere University, completed a fellowship in pediatric oncology at the University of Cape Town, and holds an MBA in healthcare management and leadership. Dr. Kambugu is continental president of SIOP Africa and serves on Uganda's National Cancer Control Plan Secretariat as the technical lead for childhood and adolescent cancers. And finally, Dr. Sari is a pediatric hemato-oncologist. She is the founder of the Indonesian Pediatric Cancer Registry, a hospital-based multi-center registry that operates across 12 pediatric oncology centers in Indonesia. And this pioneering initiative has strengthened national capacity in Indonesia for data collection and informed health policy to address systemic gaps in care. Her research interests include pediatric cancer registries, treatment delays and abandonment, access to essential medicines, and therapeutic monitoring. She has published widely in peer-reviewed journals, including many in the childhood cancer space, and she is engaged in collaborative projects such as the Profile Program and the ARIA Guideline Development Group with St. Jude Global, as well as the National Childhood Cancer Planning Team in Indonesia. So thank you to all of our speakers again, and thank you for joining us. Dr. Steliarova-Foucher, please feel free to share and make your...
Okay. Can you see my screen well?
Yes, we can see it.
Challenges and opportunities, yes. Okay,
yes.
Thank you very much for the introduction, and I'm very pleased to be able to share my experience and also some concerns about childhood cancer research in low and middle income countries that are the subject of this seminar. So I would start with this slide on which you can see the classification of countries by income level. So this is the classification by the World Bank. And you may know that this classification is changing from one year to another. So some countries may move from one category to another, both ways, up and down. So the countries we are talking about may be different set of countries depending on year and how the country is doing on economic field. So you can notice that there is an improvement in the proportion of countries that belong to higher income levels between 1987 and 2024. But there are still many countries, especially in Africa, Asia, Latin America, which are not high income countries. So belong to this category of low and middle income countries. On this slide, we can see the funding that is received for childhood cancer research over a period of 10 years. And as can be expected, this funding is also distributed unequally. So most of it is concentrated in just about 30 out of 200 countries that are visible on this map. So the funding is as a proxy for research activity. You can notice that there is about 1,000-fold difference in funding, amount of funding expended in the last, in the least versus the best funded countries. And in this study, both public and philanthropic funding was considered. We can see that the country income and the spending on research are correlated, and the funds availability is the prerequisite for research studies. So this map also shows a large inequity in availability of the funds. On the next slide, we can see the coverage of the world by population-based cancer registries. This is related to childhood population. These are the population-based registries that collect comparable data on the essential indicator, which is incidence of childhood cancer in a population. And these data are needed to assess the dynamics of cancer occurrence. Because cancer is rare in childhood, it is important that large populations are covered and also that data are shared across countries, so that it is possible to evaluate variation in incidence between populations and over time in a standard way. These data then can serve policymakers to plan cancer control and evaluate the success of cancer control programs. Some of these registries that are represented on this map also follow up the registered patients so that they can also assess survival. This means that patients that do not start or those that abandon treatment are also included in the statistics and the control measures, and they are taken into account and not just the differences between different treatment modalities, because we know that in low and middle income countries, there are children that may not get to the adequate care, and also some of those that start treatment may not finish it. Although you may see that some low and middle income countries are represented by population-based cancer registries, the patterns seen on the previous slides seem to be repeated, with only approximately 5% of childhood population covered in Africa and Asia, and around 15% in Latin America. In addition to using registries for health policies, they also produce data that can be used for research. The registry collects more and more information on each registered patients, and this is especially typical for registries that are focused on childhood populations, so pediatric cancer registries. For example, we are coordinating study cancer risk in childhood cancer survivors, which is built exclusively on data collected by cancer registries on a routine basis. And this study using these routine data, we can evaluate the risk of second primary tumors that occur in patients that survived their first cancer. So to support the development of cancer registration, IARC has teamed up with St. Jude Children's Research Hospital to set up a child GICR program, which is embedded into the pre-existing global programs in both institutions. This child GICR strives to implement cancer registration in countries. We work on capacity building and research. In 2021, we ran a child GICR masterclass, which resulted in a cohort of currently 18 trainers in childhood cancer registration who can disseminate their expertise further to other people who that are interested in this area, and those who want to establish or continue cancer registration in children. But of course, the expertise is not sufficient to have good data on childhood cancer. The support is needed from governments, from charitable organizations, from patient support groups, and other stakeholders. But at the same time, data produced by a cancer registry are excellent means for advocacy, so that data collection becomes part of a virtuous cycle of knowledge creation and dissemination. So, but the most important element of success to create information on childhood cancer are the people who are involved. These are knowledgeable, determined, and energetic colleagues who are able to seek support, organize registry work, and engage all stakeholders. Such local champions are not only required, but they also exist. And there are two of the trainers that are on the panel who are also involved very much in development of childhood cancer registration. So this is the success story that I wanted to share, and I'm very proud to have a very tiny involvement in this, but the main credit goes to Dr. Radhakrishnan Venkatraman, who has imagined, set up, and launched population-based childhood cancer registry as first of its kind in India, and as an example in low and middle income countries. So this registry was launched in January together with the report, and of course also with acknowledgement of all the funders. So, well, this is in very short my experience and some ideas I wanted to share, which are very heavily biased towards cancer registration, but I think that data is the basis for development of the policies, but also for development of research, including on childhood cancer. Thank you very much.
Wonderful. Thank you so much for those comments. I'll ask the audience to hold any questions for Dr. Steliarova-Foucher until our panel discussion. And now we will turn the floor to Dr. Kambugu, who will speak from the African perspective and her experience. Dr. Kambugu, I see you speaking, but you're on mute. So
oh, I had muted myself. Thank you. Yeah, so hello, everybody. And I'm very pleased to have this opportunity to speak to us about a topic that is recurrent in all of our minds, more so on the African continent. I thought that I would speak about our experience or our knowledge of research from the Africa perspective, but maybe some of these things might be translatable to other LMIC settings. And I chose to reframe the question a little bit, and you'll see how. So for a very long time, Africa has been called the dark continent for many, many reasons, but one of them is the fact that there's hardly any data, and Eva has already substantiated that, even from a registry perspective. So this is not new. And as you know, a dark continent, it's void, there's nothing there. This has happened and we've had it a lot. And I just put an example there of text that I see all the time. Very little is known about this condition in Africa. There is insufficient data from Africa to say anything. I mean, this is a sentence opener in many epidemiologic texts. And sometimes it gives the impression that there is no work going on in Africa, or there's nothing that Africa has to say, and so forth. But the truth is that there's a lot that we can say from my perspective as Africa. And I wanted to use the analogy of something we have a lot of in Africa, which is the calabash. It's this, big pot. You can put nothing in it, but sometimes you can put so many different things in it. So really, Africa is full of so many things. We just needed to change our mindset in Africa. There's lots of data. There's lots of questions that could be asked that haven't been answered. There's lots of wisdom within the continent. The real question is not emptiness, really. It is really, do we know what we have? Do we value it? How are we using it? Because many times we misuse this information or these opportunities. Many times we try to mimic others that we think are doing better or can answer questions better. And many times we work in silos. We have similar problems, but many of us are trying in our own little ways to solve these problems. And that, I think, for me, is one of the biggest challenges we have in Africa. And so I wanted to use an analogy that will help us see the different phases of research in Africa. There are really 4 different phenotypes, if I could call it that way, of research in our continent from my estimation. So this 4x4, this 2x2 matrix, to me, represents how research is seen in our continent by us or others, right? By us as Africans. And on the vertical axis, you can see the lower bit is the victim, where we're like, oh, we have no money, or we have too much time, our patient loads are massive, we just can't get around to this. Basically being the victim, right? And we can identify with that many times. Or you can be the leader in this. And on the horizontal axis is where we have this copy-paste type of research, not thought through really. You're just copying and pasting something that's been done elsewhere. And then, of course, there's where the research is context-tailored. And I wanted to explain these using an analogy that's very common in my country, where you have this man with a massive extended family living under his roof that he has to support. And his compound is full of weeds. They've grown right up to his doorstep. And how he responds to this situation really, to me, mirrors how we respond to research in Africa. So if you look at the lower quadrant, the red one, what I'm calling the deficit zone, this is the victim who copy-pastes, and it is the absolute worst. It's akin to the man, he has this house, he has these weeds, and you're saying to him, there's going to be these snakes, why don't you do something about it? And he says, oh, I need to go to the garden to plant, because how will my household be fed? I have no time, I have no money to buy a slasher or a panga. Basically excuses, and basically giving up power, giving up agency, and just letting other people think for him. In the orange one, which I'm calling the adapter's trap, that's the victim, but who tries to be a little bit context-tailored. So this is, the situation where we have all these different neighborhoods, and I sit in my house and I'm like, okay, you know what, let 2 of my kids stay back. They can try to pull the weeds. And then somebody else says, oh, maybe we can buy this one panga and one child can stay back. So we're all different, trying to find solutions to a common problem, but we're so siloed. And because we're siloed, our information is not impactful or cannot be generalizable, translatable, because we're working in silos. And that happens a lot for us in Africa. We don't really work well together. This adapters trap is slightly better, but no, really, And then we have the kind of people of a concept, which I'm calling prestige mimicry, where it's the leader, but the leader has not yet taken command of the space. And so this is the guy who says, okay, you know what? I saw those guys using the diesel operated machine. Let me go get it. It's very efficient. He'll slash the grass and so forth, but he can't sustain the operational costs. The diesel needs to be bought. The maintenance needs to be done. These are things that are not very manageable within his context. So it's a start, stop scenario. So that also isn't, And then there's where we're trying to go as African oncologists, to really be proudly African, to do research for Africa by Africa, that's context specific, that pushes the pencil. And that's where we are. So a lot of us in Africa are lying in one of these boxes, but moving towards the ideal, which is the green spot. So I want, therefore, to quickly switch to the challenges, but really coach them as opportunities right now so that we're not victims, but we're taking command of ourselves and of the problems that we have. Yes, we have overwhelming patient numbers in many LMICs, but definitely in Africa, we're resource constrained. There's just too many people. And you can fall into the trap, the victim trap, the deficit trap because of this. But by the same token, these huge numbers are our strength, because we can leverage these patient volumes to answer questions in a meaningful way that can actually inform the world. Yes, many times we work in ad hoc siloed, ways, but if we work together, and this is starting to happen in Africa, where the different countries or hospitals are coming together, asking questions that are similar to them and finding solutions, pulling their data and so forth. So really this ad hoc siloed can be an opportunity for us. Then there's a whole big trial paralysis. We don't feel like we can. It's too difficult or it's too complicated and so forth. But we don't have to be doing clinical trials. Clinical trials are not the only research. And there's that mentality in Africa. There's so much that we can answer that's pragmatic, that's relevant and responsive to our situations. And so that's a flip that we are hoping to achieve. And then a lot of the things that make us not engage in the research is because you're one or two pediatric oncologists in your hospital, and you're so overwhelmed, and you think that the only people you can actually do research with are fellow doctors. But the truth is, we can task shift. We're already task shifting other things. So why not work with the people around us, like the nurses, the nutritionists, the psychologists, the social worker? This has already been demonstrated in Africa, in the TB world, in the HIV world. And so we can work with those that are around us. We can't wait to have 10 doctors in the hospital. That will never happen. And then, of course, we need to stop doing research for its own sake that doesn't really answer our questions. We've gotten a question that's been asked somewhere in the high-income countries about some monoclonal antibody X, or I don't know, small molecule Y, and then we want to do that research, but it's not responsive to our real problems. And that's a problem for us. We should be answering things that push our own pencil. Then, of course, fear of things, like fear of AI. That's one of the big examples. Fear of embracing it. Yet, if we claim it as Africa, we can actually answer our own problems in a unique way. So really, I want to end, because I have very few minutes, by saying that really in Africa, we need to find a way of rebalancing the table, or in global oncology. We need to make sure that our high-income partners also practice what we call cultural humility, because it's not very common for them, you're a collaborator with them and they say, oh, send us 5,000 words in. And yet the time availability is not the same for us and them. But we also have to rise to the challenge and know that, yes, we have patient numbers. Maybe it will mean I have to burn the midnight oil. I'll have to move out of my comfort zone. But let's rise to the challenge. Let's also push back. Let's say, could I have 2 more days? You know, what if we did it this way? And our high-income country partners should not practice tokenism. They should really include us, you know, and mean it. And knowing that if we don't tell our story, other people are going to tell it for us and write us out of the story. And this has happened many, many times, and we want to change it. So we really need to be doing research for Africa by Africa and hoping to have partners working humbly with us and stop living in the deficit zone. We need to think about questions. We need to act. We need to do research that pushes the pencil. And that's it from me. Thank you.
Thank you so much, Dr. Kambugu. That was wonderful and a lot of food for thought there. Dr. Sari, we turn to you now for your perspective and experience in Indonesia. Thank you.
Hello, everyone. First of all, I want to thank you for the opportunity for me as no one here to share my experience, just common pediatric oncology, and very inspired by Dr. Eva and by Dr. Kambugu for the experience of Africa. I want to declare I learned a lot from Africa, from Indonesia. So I want to start my little story, my short story, how I developed the first multi-centers cancer registry in Indonesia through Indonesian Pediatric Cancer Registry. So just like inspired at that time, I just like the new fellow. I just don't want to be accepted to Indonesian conditions because I believe, like Dr. Kambugu already said, Indonesia big countries, a lot of patients. We have big resources, but why our situation, especially in childhood cancer like this? At the time, I just think where I should start it. And then my supervisor told me, just do the registration, the cancer registration. And then I go pursue to another hospitals to study about the principle of the cancer registrations. And then from the small university grant, I just try without enough knowledge about the cancer registration, started to collect the variables. And then that time it's very messy because I try to collect so many data and so many unfilled variables. And then at that time I cannot conclude anything because too many data, too many missing data. I can't conclude anything. But at least at that time I have insight. I have to manage it well. And through my job methods, I have the capability to expand the cancer registry is more structured way. So I try to mix, expansions into 12 hospitals. First, I do piloting in my hospitals. I have Dr. Sumit Gupta as my supervisor. I learn a lot from him. And then I try to have like a system strengthening. And the problem is, since Indonesian cancer registration is not really built on the structured way, it's very hard to have the connections with the population cancer registry who had this more stable funding. So during this day, I try to finding from one grants into another grants. So finally, with the help of the collaborations through Princess Maxima Hospitals and through the World of Child of Cancer, I have the grants to improving and try to like digitalizations and collaborator to mix our tools as as cheap as we can, and as the simple as we can. And this and the end of like 2023 to 2024, we try to consolidate what in our registration is. So Indonesia, big countries, through this grant, I only can to catch up almost maybe like a half of the hospitals that provide childhood cancer services, because like we have to do all the administrations by the grants. So I select the hospital firstly is not from how many patients they had, but first, is there anyone who willing to taking care and obligate to make sure all the data input to cancer registry is valid. So first, I looking for friends to do the willingness to do all the registration, because it's just like one time program. It should be sustained. Maybe if you try to grow the plant, we will take the fruits maybe after years. That's why after like I want to prove to them, to my friends, to other pediatric oncologists, we need the data. So keep collecting the data. I give them a feedback. Please, you do some analysis. Is there any quality improvement can be take from this data? So I always do the monthly or quarterly report for each hospitals. And finally, from day by day, years by years, we can increase the numbers of patients included in the registry. And finally, from this data, we can make something that, for example, we will like target it for the target guidelines, procurement drugs. So usually Ministry of Health use our data to have like drug procurements, and which of the supportive care that we the needed most, because like we collect, because we are hospital based, we mostly talking about the services. So we want to actually integrate it to population base. That's why after I read Prof. Venkat journal, as soon as possible, I connect with him, and I asked, what is your recommendations to pursue integration from these multi-centers hospitals to population based? Because like as long as I know, the China is the only one established a population based cancer registry. So the challenges, like maybe Professor Dr. Kambugu also already taught, like the bigger country and the LMIC always about the technical and resource constraints. But like you said, we cannot accept the excuses. Like Asian country, like Indonesian countries, maybe easily to accept the excuses. Oh yeah, we cannot do that because there's no many people in my hospital. Oh yes, because our patients come too late. So we accept everything. That's why we cannot move from this situation into the better situations. So we try to accept the challenges with. We try to utilize the data more, make many publications so we can prove that the data is very useful. The data can help to improve the survival. The data can help the patients in the end. So, but still, because Indonesia is too many administrative things, because like I spend maybe before I establish the formal registration, I put like a quarter, 3 months just only for the legal aspect. So I try to talk one by one hospital to accept their approval. So somehow it's very overwhelmed, But if you believe this initiative, the data will make some impact to your patients, so yeah, we have to do that, because like we have to accept, we have to see our context, what it needs. And still the integration gaps, because if we have a lot of patients, still our data cannot be entered, for example, in the global can, because our hospital data is not integrated into our population-based cancer registry. So how we overcoming challenges of the registry? So we keep on the capacity building, training registrar, clinician, IT staff, doing so many Zoom meetings, quarterly Zoom meeting to make some feedbacks to other centers, because like we want to improve the data quality, unless garbage in, garbage out, right? So we try to improve. We have the quality indicator of each centers, and try to have something how we improve the data quality involving the end user. And I was to talk about the Ministry of Health. Do you want another data from our registry? And then we want to make some like implementation research, like iterative prototype testing, to ensure the system meets the real clinical and operation needs. And as I mentioned before, our dreams and our wishes is to integrate into our population-based registry. But since our population-based registry is also not strong enough, so we want to grow together with our Indonesian's population cancer registry. And of course, collaboration's a big key point. So during this period of the iterative prototype testing, I always engage with the Ministry of Health, showing the data, and then hospitals, and try to integrate our registry into our active programs like abandon preventions, quality improvement, clinical guideline developments, and also uh, we have to convince the stakeholders they need our data. So here our daily activity, like from training, try to collaborating, and then we have like monthly, daily routine discussions, and we want to have like our programs in national scale up. So we try to have like advocation to Ministry of Health, like each hospitals that provide childhood cancer should be mandatory to do the hospital-based cancer registry. That's why we try to modify, simplify our variable into more simple way, and prioritize which indicator, which variable that we want to collect the most. And our future directions also in conjunctions with integration with Profencore, like CNA Population Cancer Registry. We want to, not copycat, but maybe adapt some of the way of Shena collecting the data. And we always try to have like advanced analytic, do some GIS, something like that, and try to to use continuously our data into policy and advocacy. But still, the problem is the sustainability, because we cannot, rely on the grants forever. But still, that's why we're working also into the national childhood cancer program, and put on the registry is the basic one. And of course, like innovation is very important also. Like Joyce have said, in LMIC we have our contact, we have the uniqueness that maybe in a high income country cannot found. That's why we try to deep on our data to use and try to have mutual impact and very significant impact to our patients. Thank you.
Thank you so much, Dr. Sari, and to all the panelists. And we'll now open the floor for discussion. Feel free to either unmute and say your question or put it in the chat, and I will look for those. And while we wait for questions to come in, I have a question from Dr. Kambugu, following up on something that you said. So you mentioned that collaboration and not working in silos is key, in your opinion. Do you have some examples of really successful collaborations between hospitals that could be built upon or used as a success story, or even between borders in Africa?
Yes, these are becoming increasingly more in Africa. I think perhaps the most famous one are the CanCare studies on Wilms tumor that kept building. And this was at about 11 different sites in Africa, really to decide what is the best way to treat Wilms tumor, cognizant that many sites don't have, say, access to radiotherapy. Is there, and there were iterations of improvement, and those results were published. So that one is, multi-country. But there are others also within the same country that are emerging as well in different types of countries. One of the most successful ones, I think, is in South Africa, even though it's upper middle income. But one of the things that I admire that we are trying very hard also to do in the rest of the continent is the harmonized protocols. Because after a while, there are different sites. They now have, I think, 11 different sites. And they have gotten their tumors now and harmonized their approach to those tumors after a long time. And now all the different sites are using the very same protocol, which I find very good because then they're able to tell. As an example, the baseline for Hodgkin's, for example, which we're using now as well, was being able to tell which of our sites is using what and how well are they doing, and that informed their national protocol now. And we are planning to do that in Africa as well with the Hodgkin's protocol, with bucket lymphoma. So let me not take up too much of the time, but there is precedent now increasingly in Africa.
Wonderful, thank you. Any other questions from the audience for discussion? Well, oh, I see one coming in the chat. For registry set up in Indonesia, Dr. Sari, was there a method by which duplications were handled? That's from Mohiba Ali Kawaja.
Yes, thank you, Dr. Ali. So firstly, when I got my first grant, because it's very small grant, but I'm happy because I have a friends. It is a computer engineering who willingness to help me with a small budget. But at that time, I was too ambitious. I want to collect so many data, and then I got failed. And the time I just like more smart, and then I tried to make so like with the guidance of my mentors. Then I found also very customized, because like doing some established like the, maybe at the time there are no SG cares yet. So what we have like Kenrec 5 at the time, but still languages is our barrier. So I have to make some Indonesian versions. So I invite all the stakeholders, and then which variable do you want? So I make some prioritizations, and they make is some web-based customized registries. This looks like Kenrec 5. At the time, I want to have like, at the time, because we collect data prospectively, it's just not like population-based, usually collect the data retrospectively. So Indonesian Pediatric Cancer Registry, we collect prospectively because we believe through the registry, we can prevent abandon, because we want to have our patients at the very beginning, and then we want to guide them through all the all these procedures. And that time, but it's too costly because I have to buy the maintenance, because when you make some engineer, because we are in an engineer background, we still hire them, and we I have to have a budget for them. And finally, we have found RedCap is a free software, and still we can make it in Bahasa. So right now we already moving from my previous applications of software is web-based to RedCap. There's a plus and minus, but yeah, because we have to sustain, we have to spend our budget as long as we can. So we have to modify that. With the help, maybe Ibrahim is the data manager from the Princess Maxima. He helped me, and also the African partner to the RedCap. So there are some variables that comparable, but there's some variables that designed for Indonesian specifics. Like we want to prevent abandon, so we make spatial variable for abandon, something like that.
Thank you. Any other questions from the audience?
Yes, I have one. It's more a comment. I'm Brenda Mallon. I'm talking to you from Paris for the French African Pediatric Oncology Group. I'm just delighted to be here and listening to all the wonderful work that's going on. I'm wondering how we avoid different investors or donors who would like more information on chemotherapy or on whether people are covered with social security or whatever, and how we minimize, because it seems like Dr. Sari, one of your problems was actually reducing the number of variables that you had. There's always the temptation to have loads and loads of data, but how do we avoid having that, and how do we reduce and do? That's one of the things, but also collecting data on chemotherapy, how a register, how I'm wondering what Ava thinks about that. And the other thing is, I think it's just to note the importance of having people who help us, like My Child Matters, that helped us greatly in the GFOP. And just lastly, just a little comment and something to say about the French African group, that we have expanded protocols that actually work in lots of different countries in Africa, and that produce quite a lot of research. One of our projects at the moment is really bringing up and training young African researchers so that they will start developing skills in manipulation and analysis of data. And I think it's something that's really important as well for the future. Voilà, that's all really. There are more comments, but one question for Ava anyway. And thank you all. It was really, really interesting. Thank you.
Thank you very much, Brenda. Can I then, as I was put on in the spot, so Brenda is one of our trainers that were trained during Child GICR masterclass, and of course the question of funding is fundamental, because without money to support whatever data collection or research studies, well, it's not sufficient. In addition, for cancer registries, really the funding should be on long term. It's not sufficient to have 2-3 years of registry, because that's not really useful. So this is also why it should be really interest of governments to support this type of surveillance, because they should collect this data to be able to support their population and the children in their population. Then how to avoid duplication. Well, maybe one of examples is a meeting like this where we could share experience and we could share information about what everybody is doing, and this way there could be discovered some synergies or needs that could then be brought further either to the funders or as collaborative projects. So, well, I don't know if I answered, Brenda, your question, but yeah, I think if we knew the answer, we would be further yeah, in our efforts. Thank you.
Yeah, thank you.
We have one more question in the chat, and then I have a closing reflection or question for all three panelists. But first, Dr. Sari, for the Indonesian registry, would you elaborate on how you collect data from hospitals without established electronic medical systems?
Yes, thank you. So firstly, at the beginning, we want to collect because like in Indonesian Pediatric Cancer Registry, at that time we have like a packages, like the general packages or each disease packages. So as our first period, what we want is just to have the frequency of the disease and the follow-up. We don't want to know what happened during that, but I want just like what kind of disease, what the ICD-10 code, what as the last follow-up, is the patient die, abandoned or something. At that time, it's very easy, but actually still as the clinician, we want to do something, right? Because we are tempting to do some clinic duties. So we have to select, we have to choose. So in line with what project, what protocols right now currently running, because Indonesia, we don't have so many running protocols right there in the same way. So we start from Indonesian Leukemic Protocol 2024. So we use this registry as the monitoring and prioritize leukemia detailed clinical data. So we have to prioritize. And without any established electronic medical system, we still have the paper base. So we give the hospitals like data dictionary, the paper-based one, and then the electronic one, and we send the dummy if you want to exercise. So we give the options, but in the end, because like data sharing is something that's very crucial in Indonesia, if the centers still want to use our way to collect the data, please use. You don't have to share with us. You just use the data for yourself, for the hospital itself, for sake, for quality improvement. So some of hospital in Indonesia, not including in those 12, still collecting data with paper. And then maybe they want to make like small research, because I'm very happy if there are some publications using our data. It's mean the data is talking. Thank you.
Thank you. And to close, thank you again to all of our panelists and the audience for the wonderful presentations, thoughts, and discussions. And just a closing question that I'll pose to our three panelists. If you think about something achievable, feasible, that we as a broader cancer community or in your context could implement or change or strengthen in the next 5 years to make the most impact in moving forward research, generally research capacity, what would that be?
Well,
Maybe
maybe I
it's a
will
difficult
I will
question.
start as before. Well, for me, again, it's really cancer registration, because that's is missing in most low and income and medium income countries. And this is really the basis for a starting point for research and for improving the situation. We first need to know what's happening and what is the cancer burden in the countries. So, and this is what we try to do with Child GICR. It's not easy because we cannot do it from here. We need engagement in the countries so that we can help provide technical support, standardized methods and so on. But the initiative has to come from countries, as it was, for example, Dr. Venkat has shown, or Dr. Sari. Thank you.
So for my side, like Indonesian perspective, what I do like maybe in this like 1 or 2 years, like 5 years, my priority is to use the data for policy and advocacy in lining with our national action plan, because we have the target and we use IP core data as the baseline. So we push the ministry, you use our data, you should funding us. I don't know how, but it should be like mutualism, because like ministry want to evaluate their any interventions, but if you think is important, so please make structure for us. So it will be my priority for a few years from now. Thank you.
I've been thinking about your question, Erin, and it's a very difficult question to answer because it's very multifactorial and very heterogeneous. And if it was easy to answer, then of course, research would already be happening, especially because in Africa, especially, it's not that there's no research. There's a lot of research happening in communicable diseases sector, in HIV, in TB, there's so much research happening, but why is that not the case in pediatric oncology? And that has been the problem. So one of the things that we are putting a lot of emphasis on is collaboration, because many of us feel very isolated where we are. Many of us are the first pediatric oncologists in the unit or the country. And some countries don't even have a pediatric oncologist. So you feel very isolated because there's nobody you can talk to or work with to start and so forth. So we are encouraging a lot the collaborative groups, and we've started now with working groups. Already we have about 6. And we're finding that sense of togetherness, to begin to understand where can I start, how do I start, what do I need, how did you do it, is beginning to yield a lot of traction. So we have, for example, this happening in the bucket lymphoma group, already very nice, in the acute lymphoblastic leukemia team, very nice to just understand how do we capture this data, how do we do this despite. And so I would put a lot of energy in that. At least that's where we have started, because it begins with the person. Like Sari is saying, she started this, she energized it, she moved it. So if we can just get that to happen and empower our pediatric oncologists to feel you're not alone, you can start, you can go this way and that. I feel that is also a vehicle for improving capacity and innovation.
Wonderful. Thank you for all of your thoughts, and thank you again for the discussion. This was very engaging, and I personally really enjoyed hearing all of your perspectives. Thank you. And just a note to everyone, the SIOP Epidemiology Network hopes to hold more of these discussions in the future. I hope if you are not already a member, you will become a member of our network. And we look forward to seeing many of you, I hope, at the SIOP Congress next month. Thank you, take care, and have a wonderful rest of your day.
Thank you, bye-bye.
Thank you, Dr. Kambugu, Eva, thank you, bye-bye.